Okay, so let's get the ball rolling. Welcome today. Today's class is on approach to upper GI bleeding. Approach to upper GI bleeding, as you do. So today we're going to review the topic approach to upper GI bleeding. The rationale for this is upper GI bleed can manifest as either hematemesis or melena. So hematemesis is vomiting fresh blood or vomiting blood, let me say. And usually melena is dark, tarry stool. And melena is pooping blood. Okay. What the objective or the rationale of the objective is saying is a patient can either pick up upper GI bleed with either what the patient is vomiting or what the patient is pooping. And it always warrants careful and urgent evaluation, investigation, and treatment. Now, the management depends on the amount of blood loss. And you realize that I'll be quizzing you as well as the class goes on all these various scenarios you may have to encounter in your clinical practice, and as you also prepare for the MCQ1, in terms of the amount of blood loss, the patient's hemodynamic status, and what you have to do. The likely cause of the bleeding and the underlying health of the patient. So three things which determine how you're going to manage a patient with upper GI bleed. Number one, the amount of blood loss. Number two, the cause of the bleeding or the likely cause. And number three, the underlying health of the patient. Does the patient have a coagulopathy or does not have a coagulopathy? Is the patient taking an anticoagulant or not? Does the patient have portal hypertension or not? All these are going to affect the way you're going to manage your patient. Now, the causal conditions. So remember that I told you that the trick in mastering the exam is you go in there, you look at the causal conditions, you list all of them, and then you also go to the enabling objectives, and then you look at all the things that are stated in the enabling objectives. And based on what is stated in the enabling objectives, you can use that to, know exactly how you're going to prepare for this exam. Okay. So what are the causal conditions the medical council wants you to know? Number one, ulcerative or erosive processes like peptic ulcer disease. So if I were you, I'll write it down. I'll make sure I master peptic ulcer disease. And those in MedCognito, you realize that we've already dealt with peptic ulcer disease for you. Esophagitis as well must be dealt. Gastritis. These three topics, you must master them. Number four, you must master portal hypertension. Number five, you must master malorified tears. Number six, you must master tumors of the upper GI tract, like esophageal cancers, stomach cancers, So this gives you something like topics you need to master, a study plan. So if you look at what we have provided for you in your MCQ1 study planner, doctors, who does not have the study planner? I want to know. So please, if you don't have it, let me know so that I'll send you the link right away and you can download it. I go on. The key objectives. So given a patient with hematemesis or melena, the candidate will diagnose the cause, the severity, and complication, and will initiate an appropriate management plan. In particular, now look at this. The candidate will determine and manage the hemodynamic status of the patient and resuscitate if necessary. So while you are learning this, please make sure that you are paying attention. If I should quiz you, make sure that you are paying attention to the hemodynamic status of the patient. How I describe the hemodynamic status. Is the patient in shock? Is the patient not in shock? Those are the things you want to pay attention. The enabling objective. Given a patient with upper GI bleeding, the candidate will, number one, list and interpret critical clinical findings, including the cause of the bleeding as determined by the clinical history. So you realize that the cause of upper GI bleed secondary to malorified tear is totally different from the cause of upper GI bleed secondary to peptic ulcer disease or secondary to esophagitis or secondary to esophageal cancers. Okay, now the results of an appropriate physical exam, notably aimed at assessing the patient's hemodynamic stability. Again, you have to just ask yourself, the medical council wants me to know this. How do I determine a patient's hemodynamic stability? How do I determine that? With some vitals, like even from my history, is the patient dizzy? Does the patient have some chest pain? Does the patient have palpitations? From my examination, what's the blood pressure? What's the pulse? What's the respiratory rate, right? How are the extremities doing? Those are the things I want to pay attention to. And look at another thing, because I'll be focusing on this in the class today. Indications of a high likelihood of bleeding. So if you have somebody with peptic ulcer disease, what indicates that this patient may bleed again even after you treat the patient? If you have a patient with malorified tear, what are the risk factors for rebleeding after the patient has had an initial bleed? If you have a patient with portal hypertension secondary to cirrhosis, what will I do? Or how will I know that these two patients, This one is likely to bleed again. This one is likely not to bleed again. You need to master it because the medical council wants you to know that. List and interpret critical clinical investigations, including endoscopy, laboratory and diagnostic imaging as appropriate, and construct an effective management plan, including resuscitation of the hemodynamically unstable patient as a result of the bleeding. Number 2, medical treatment as appropriate. So if the patient has portal hypertension, is there some medical treatment we can give? If the patient has esophagitis, is there some medical treatment we can give? If the patient has peptic ulcer disease, is there some medical treatment we can give? What medical treatment can we give? Based on the various clinical presentations, the patient will come to the emergency room or the clinic with. Determining whether the patient needs immediate specialist care like gastroenterology, like general surgery, like intensive care unit, and instituting preventive measures or treatments to avoid rebleeding. So what can you do to prevent rebleeding in a patient with vagal varicose bleed? What can you do to prevent rebleeding in a patient with portal hypertension? What can you do to prevent rebleeding in a patient with peptic ulcer disease? Doctors, these are the things, and that is why I always say, please, 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 it is not enough to say, I've picked this book and I've covered the book cover to cover. So if you want to use Toronto Notes, Master the Boards, whichever book you want to use, please make sure that you've listed these enabling objectives and you've gone into the book and you find them. If they are there, if they are not there, go to Dynamed, go to Up to Date, all right, and use those resources to really find them, because these resources are there. The medical council wants you to know. And if you are not using the objectives and the enabling objectives as your study guide, you are likely to just, read all over very important information and rather master things which are not very critical for the exam. Remember that with upper GI bleeding, we've been hitting on hemodynamic status. The hemodynamic status will guide you to know exactly what to do so far as whether you're going to manage these patients as an outpatient, inpatient, ICU. Okay, good. Before we zoom in, any other person with any question before we zoom in? Okay, good. So it looks like there's no question. So we're going to move into malarivice there.